Question 51 asks, which is the most appropriate next step for a white or red lesion that does not resolve in 2 weeks? So option B says monitor. The 2 weeks was the monitoring phase, so further monitoring would be unnecessary and would actually prolong the situation instead of helping it, so this would be incorrect. Option C reads prescribe antibiotics. You don't want to prescribe antibiotics without knowing what the lesion actually is and its cause, so this could be dangerous and is incorrect. Option D reads excision. We want to know what the lesion is before proceeding with any treatment, so this is incorrect. Leaving us with option A, biopsy. For an intraoral white lesion, leukoplakia, or a red lesion, erythroplakia, or lesions that have both erythroleukoplakia, you want to do a biopsy if they don't resolve in 2 weeks. These lesions can be precursors to squamous cell carcinoma, which is the most common malignancy of the head and neck. In fact, even though erythroplakia and erythroleukoplakia are less commonly found, they are more likely to undergo malignant transformation. So it's important that we do a biopsy. So this would be the correct answer for this question. Question 23 reads, each of the following is required when obtaining informed consent for protective stabilization except one, which is the exception. Obtaining informed consent is very important when using protective stabilization such as active restraint or using a device and passive restraint. So option B reads, in-depth discussion of the procedure. Explaining the process and why it's necessary to achieve the child's guardian's approval is required. So this would be incorrect. Option C reads alternative treatment option discussion. It's important that we discuss different options such as doing nothing or general anesthesia. This is a requirement and this makes it incorrect. Option D reads patient's name. Patient's name is required when obtaining informed consent, so this makes it incorrect, leaving us with option A, information pamphlets. Information pamphlets are recommended to help explain the process, however, they're not required, so this would make option A correct. So question 26 reads, 15 minutes after administering propofol, the dentist notices the patient begins to breathe heavily, using her accessory muscles to breathe and is climbing to the touch. The dentist rechecks her vitals, which show a pulse at 114 beats per minute and a pulse oximetry at 88%. 3 minutes later, the dentist notices a sudden cessation in breathing. What is the next best step? So here our patient has signs of respiratory arrest, like tachycardia, accessory muscle use, drop of pulse oximetry, and breathing heavily, which suddenly stops. She also has a history of severe obstructive sleep apnea, and the doctor gave propofol, so this is going to increase the risk of respiratory compromise. So propofol is an anesthetic, and when given to patients with obstructive sleep apnea, it can actually lead to an increased risk of respiratory compromise and hypoxemic events. So if you want to give a patient like this an anesthetic, you would want to give a shorter acting anesthetic that won't affect the patient's breathing as much and is metabolized quickly. So option A reads administer adenosine. So this is used for arrhythmias, and we use it in emergency situations to treat supraventricular tachycardia, but it has no effect on treating respiratory arrest, so this would be incorrect. Option B reads administer atropine. So this is an anticholinergic drug, and we use it when you want to treat bradycardic patients to help speed up the heart. It has no effect in respiratory arrest, so this is also incorrect. Option C reads administer aspirin. So aspirin is an over-the-counter non-steroidal anti-inflammatory drug, and it's also used as a blood thinner. It doesn't have an effect on respiratory arrest, so this is incorrect, and it leaves us with option C, call emergency medical services. So this would be the next best step because they would come in and help ventilate the patient's airway to help save them, especially if they've already reached a state of no breathing. So this would be the correct answer for this question. So question 38 reads, this patient is requesting the replacement of amalgam fillings with composite fillings because they read that amalgam fillings are toxic. What is the next best step? So amalgam fillings, similar to this image, are made from mercury, silver, tin, and copper. There is no toxicity associated with placing an amalgam filling, and allergies to these fillings are actually very rare. So option A reads, replace the amalgam fillings with composite fillings. So considering there is no toxicity associated with placing amalgam fillings, doing so would violate the ethical principle of veracity, because doing so would be dishonest. So this would be incorrect. Option B reads, place dental crowns. Again, there is no need to replace the fillings because they are not toxic and the patient is not allergic, so this would be unnecessary. So this would be incorrect. Option C reads, refer to the patient's physician for allergy testing. There is no clinical finding of allergic reaction or toxicity, therefore this is unnecessary, so this would be incorrect. Leaving us with option D, recommend no treatment at this time. So again, because there's no scientific or clinical reason to assume an allergic reaction or toxic reaction to the amalgam, there is no reason to remove the amalgam or replace it. Therefore, no treatment is the best step to take. So this would be the correct answer.
What concentration of fluoride in drinking water is optimal for dental health? Fluoride is an effective and safe way to reduce caries risk and to prevent the progression of decay. It can be found in many different mediums such as toothpaste, mouth rinses, and gels, but most of these are topically applied. While topical application does have advantages, some patients may also benefit from systemic fluoride use, which can come in the form of either fluoridated water or fluoride supplements. Fluoride can be found naturally in many sources of fruits and in water, but community water fluoridation is one of the most effective ways to ensure that populations are all receiving access to some sort of fluoride. That being said, the level of fluoridation that can provide benefits to reduce tooth decay is much likely higher than the level that would be optimal for dental health, but we do have to consider the risks and benefits. The major benefit would be the reduction in tooth decay, but there is a likelihood of fluorosis if excess levels of fluoride are consumed by children who still have developing dentition. So generally, children between the ages of 15 to 30 months are at the highest risk of this. When we talk about the optimal levels of fluoride for dental health, this is a level that has been found to maximize the benefits of preventive care and minimize the risk of fluorosis. So considering that, the correct answer to this question is 0.7 parts per million of fluoride, making C our correct answer. Studies have shown that 0.7 parts of fluoride per million parts of water is effective in balancing the risks and benefits of fluoride and has been associated with a 35% reduction in tooth decay in both children and adults. We can often see fluoride concentration as parts per million or milligrams per liters, but these mean the same thing. Looking at our other option, D reads 7 parts of fluoride per million parts of water, and this answer is incorrect. Although we would be getting higher levels of fluoride, which can help with the reduction of tooth decay, it would likely flip the balance and we would have higher rates of fluorosis and not provide as many benefits as we would hope. Options A and B are also incorrect. They read 0.007 and 0.07 parts per million respectively, and these levels of fluoride would likely be too This question reads that each of the following is a specialty recognized by the American Dental Association except for one. Which one is the exception? So there are 12 specialties recognized by the ADA, and they are dental anesthesiology, dental public health, endodontics. Then we have oral and maxillofacial pathology, radiology, and surgery. We also have oral medicine, orthodontics, oral facial pain, pediatric dentistry, periodontics, and prosthodontics. So if we take a look at the following options, we'll start with option A, which reads endodontics, and we do see it down here in the list, which means that this answer is incorrect as it is an ADA recognized dental specialty. The same goes for option B, which is oral facial pain. It is recognized by the ADA, so this answer is also incorrect. Option C reads dental public health, and we know that this answer is also incorrect as we can see here that it is one of the specialties. This focuses on using community efforts to prevent dental diseases, and this can include providing dental care to low-income communities, but a large part of the specialty is also policy development, assessment, and assurance. This leaves us with implantology as our correct answer, as this is not something that is recognized by the ADA. Implants can be placed by general dentists if the appropriate continuing education courses are taken. But if the patients do have more complex cases, then specialties that are qualified to handle these are those that are in oral and maxillofacial surgery, periodontics, or prosthodontics. So in addition to implantology, there are also a few other fields that are not recognized by the ADA, and they are, so of course, implantology, cosmetic dentistry, geriatric dentistry, restorative dentistry, forensic dentistry, and special care dentistry. Each of the following drugs can be used in sedation except for one. Which one is the exception? Taking a look at the patient chart, we can see that the patient is a 45-year-old male who has generalized anxiety disorder and has a non-restorable tooth, so he likely needs to be sedated for the extraction of this tooth. Option A reads benzodiazepines, and these are the most common type of drugs used for conscious sedation due to their wide margin of safety and effectiveness. They have a fast onset of action, and some, like midazolam, have a short acting duration, and they are usually commonly paired with nitrous oxide and oxygen for sedation because it itself has no analgesic effect, so it must rely on the nitrous oxide to provide pain relief. Option B reads antihistamines, and this answer is also incorrect as these are commonly used for oral sedation in pediatric patients. In general, there are two classes of antihistamines. We have the first generation antihistamines, and these are the ones that have a sedative effect as they are able to cross the blood-brain barrier. There are also second generation antihistamines, and these are known as the non-drowsy ones as they do not have a sedative effect at all. Nitrous oxide is our third option, and this is incorrect as well, as it can be used for sedation, specifically for conscious sedation. The benefits include rapid onset and elimination with minimal biotransformation. It is also odorless and anxiolytic, and it acts as an analgesic. However, this does not mean that anesthetics do not have to be used on nitrous oxide patients. We know that this patient would like to be put to sleep or unconscious during the procedure, and nitrous oxide is likely not an option for that, as it is generally used for conscious sedation only. Our only answer left is NSAIDs, or non-steroidal anti-inflammatory drugs, and this is our correct answer. These drugs do not have any anxiolytic or sedative properties, but as we can tell by the name, they do work to reduce inflammation. They work on the COX-1 and COX-2 pathways by inhibiting these enzymes to reduce prostaglandin production, and this ultimately results in analgesic, anti-inflammatory, antipyretic, and some also have antiplatelet properties, but like I said, there are no sedative properties, making this our correct answer.
अपने लाडले पापा से क्या ना मेरे